My name's Gary Redekop. I'm a neurosurgeon and interventional neuroradiologist from Vancouver. And I'd like to thank Timo and Carl and their colleagues for inviting me back. I've been to this great event several times over the years. I had the very good fortune to do my fellowship in interventional neuroradiology training at the Toronto Western Hospital now more than 20 years ago. And still owe a great deal of thanks to Carl and his colleagues there for accepting a neurosurgeon into their midst, which at that time was still a fairly big step and uncertain step, and I have been grateful since that time. That was, I've told people as far as my career went, spending that year in Toronto was probably the best thing that I did, and I worked with great people. And so the topic for today is acute dissections and ischemic stroke. I'll talk to you about the literature and my experience. For those of you who haven't been there, this is Vancouver, taken from one of the North Shore Mountains, and that little building right there is the Vancouver General Hospital, which is where I work. I live on the North Shore, so I get to go across the bridge and through Stanley Park on my way to work every day. I don't have any financial or relationship disclosures, but I got to be honest and tell you that on many occasions I have regretted choosing the approach that I used. And what we'll talk about is a little bit about the nature of cervical artery dissections and the related mechanisms of stroke and the various scenarios in which interventional procedures might be considered. So I'm not going to discuss in general the medical management of dissections. And then I'll present some of the relevant techniques, including aspects of controversy in terms of the interventional management. So a dissection is really a tear of the inner lining or layer of the artery called the intima, and you get a hematoma or blood tracking up between the layers, and this creates a false lumen, and it causes stenosis of the vessel. So if you were to look at an artery, and you can see in this schematic drawing of the carotid bifurcation, a common place for a dissection to occur, you get a tear in the intima, blood tracks up between the walls. And one thing that's important to note, and a difference between narrowing or artery occlusion in the setting of dissection as opposed to atherosclerosis, is that even though you may have a closed-off lumen, within that potential space of the lumen, you actually have normal intima opposed to normal intima. It is not the same as a thrombotic occlusion or an atherosclerotic one. Dissections can occur in a variety of settings. They can follow trauma. They can be associated with various arteriopathies such as Ehlers-Danlos, Marfan's, or other connective tissue diseases. And there may be a number that are truly spontaneous, but if you take a good history, often there is at least some minor trauma mechanism. And so minor, major trauma are common factors: hyperextension, flexion, and rotation of the neck. And the reason why that's so important is that when you look at both the carotid artery and the vertebral artery, sometimes they have a tortuous course, but in all cases, their course is intimately related to the cervical vertebrae. So you can see on this lateral CT angiogram picture the course of the internal carotid artery just passing right over the transverse process at the base of the skull. The vertebral artery passes up through the foramina transversaria of the vertebrae. At C1, C2, it has a fairly complicated course, or again, it travels through a number of passages through the bones. And just before entering the skull at C1, 2, it has these curves. And so in the setting of hyperextension or rotation, the arteries can be compressed or stretched. In my experience, apart from that, patients who have extremely dilated, or I just use the term loopy, carotid arteries especially, seem to have a higher incidence of carotid dissections, especially the ones that are not in the usual location at the bifurcation, and these are sometimes much more difficult to manage. The epidemiology of carotid dissection and vertebral dissection is probably underestimated. It's about 2 or 3% of all ischemic strokes, but a significant proportion, up to about a quarter of what we would call young strokes. There really is an unrecognized epidemic in trauma, and the closer you look, that is, the more CT angiograms or other vascular imaging that you do, especially in the setting of trauma, the more you're going to find. Dissection is really a dynamic kind of a process, and the radiographic findings can change rapidly. In this angiogram just illustrates what happens over the course of in this case, an iatrogenic wire-related dissection, you can see first run, second run like 3 minutes later, and then we actually put a stent in that because the artery went on to occlude. And so within a few minutes, the dissection can really evolve quite rapidly. Over the long term, about 90% of stenosis related to dissection will resolve. Even if the artery looks to be occluded, in many cases it will recanalize. If you have dissection-related aneurysms, they often persist, and about a third of them will decrease in size, and the resolution typically occurs within 2 to 3 months if you do follow-up imaging. In stroke, there are a few different mechanisms. Thromboembolism, which is clot forming at the site of the dissection and migrating to the intracranial arterial circulation in the acute stage, is probably the most common. If you have occlusion or high-grade stenosis related to the dissection, you can get hemodynamic insufficiency depending on the collateral circulation. That is probably not as common. And in the chronic stage, if you have an aneurysm that has formed, you can have clot form in the aneurysm itself due to stasis and then thrombus from that. But the most common scenario would be thromboembolism from clot migrating from the cervical area to the intracranial circulation. And there are some points of confusion. If you look at the literature or you talk to your colleagues, neurologists, neurosurgeons, trauma surgeons, and interventionalists have somewhat different perspectives. We deal with different patient populations. The stroke neurologist tends to see the dissections of patients who come and get diagnosed with a stroke, and then in the course of their investigation, they're found to have a dissection. So they have a high level of concern about dissections. As a neurosurgeon, we have a protocol for screening for our head injured and craniofacial injuries in the emergency department and do a lot of CTAs, and we see many subtle or minor dissections that actually get managed, and they have a fairly benign sort of a course. So we deal with different patient populations, different presentations, often different language. In the trauma literature, they tend not to use the word dissection, but BVI or blunt vascular injury, and we read different literature. But there are common points. So carotid dissection, how does it present? Unilateral craniocervical pain, most common, often a partial Horner syndrome from involvement of the sympathetics, cerebral or retinal ischemic symptoms, a lower cranial nerve palsy if you have an aneurysm forming in the high distal carotid. Sometimes the patients will actually tell you that they can hear their pulse, or they may have a pulsatile bruit. For vertebral dissections, often it's neck pain and headache, and the ischemic symptoms are, as you would expect, in the territory of the vertebral artery, which is most typically the brainstem, cerebellum, up into the posterior cerebral artery territory. And remember, the anterior spinal artery is a branch that arises near the vertebral basilar junction, and so you can get spinal cord ischemia as well. So what are the facts? We know that cervical artery dissection is more common than historically was believed. It's a common cause of stroke in the young. It's increasingly recognized in trauma. Management is not always straightforward, and we really don't have any class 1 evidence. So I'll present a case, and this is from a few years ago, prior to our interventional management for stroke, but just gives you a sense of what these cases look like. It was a 41-year-old guy playing hockey. He took a few hits. He was not a Vancouver Canuck, but often, these hits happen. This is a typical Vancouver Toronto Maple Leaf interaction. He collapsed on the ice, complained of headache, and fairly rapidly developed left hemiparesis. He was taken to his local hospital and then transferred to VGH, less than an hour. He had a dense left hemiplegia. He had a CT scan that showed a dense right MCA and already early infarct signs, and he was given TPA just under 3 hours from the onset. This was his scan. This was his CT angiogram. You can see the dissection flap in the carotid and the cutoff at the carotid bifurcation intracranially. He did not recanalize with the TPA, didn't improve. About 13 hours later, he developed a malignant MCA syndrome and herniation and went to the OR for a decompressive craniectomy, and it was a disaster. He had a very bad outcome. So that's the former era. I'll go through now a few scenarios of how we've managed dissections in the various presentations. I'm going to start with one that's not the common one, but just sort of going through, starting from the bottom up, if you will. So this scenario is a young man who actually had a dissection, a chronic healed dissection, but he had an expanding dissecting aneurysm in his neck. So this dissection did not heal, and he had recurrent TIAs despite being on a variety of different medical management approaches, including antiplatelets and anticoagulation. And when you look really closely, you can see the dissecting aneurysm, and you can see an area of stenosis. So we actually had two problems, and this we managed with a stent. You can see we placed just a regular coronary stent over the stenotic part and a covered stent over the aneurysm itself with a pretty good result, and his TIAs settled down. So that's an uncommon mechanism of stroke, but one that's managed in a straightforward fashion with interventional technique in the setting of failed medical management. The next one is a more acute presentation, again, not the most common, but the scenario of hemodynamic insufficiency. This was a female who was riding a roller coaster, actually, and she had a whiplash-type injury and neck pain. And the next day, she developed some language disturbance, and she had mild dysphagia, mild hand weakness, and she had a CT that showed a few patches of low density in a watershed distribution, clearly hypoperfusing. And when she had her angiogram, there was really very poor collateral circulation. And so this was also treated with a stent reconstruction. And you can see, in this case, we nested 3 different stents in sequence and restored the perfusion. So there was no intracranial clot migration. This was a pure hemodynamic insufficiency. Now, more recently, after the major clinical trials that showed the benefit of interventional management for stroke, in the acute stroke literature and in those studies, there was no specific either inclusion of or subgroup analysis of patients with carotid dissection or patients who had what we would call tandem intracranial and extracranial stenosis. And if they did identify tandem lesions, they didn't subdivide those into the atherosclerotic versus the dissecting lesions. So there's been a number of publications within the last year or so looking at the best approach to managing this situation. So intracranial or internal carotid artery dissection with intracranial occlusion, we know that has a low probability of recanalization with IV TPA. The landmark studies on interventional treatment didn't separately report on carotid dissection cases. There was a systematic review that looked at 12 studies, relatively small numbers of patients that had relevant information. The results were pretty good, but likely biased. And in all of the studies, the tandem lesions, atheromatous, and dissection cases were pooled together. So one of the controversies is, if you're managing in the acute stroke setting, you take the patient to the angio suite, and this is what you're dealing with. What do you do first? Do you try an angioplasty or stent or do something to the extracranial carotid artery, or do you deal with the intracranial circulation first and then go back to the neck? You have to get across it some way. So this is an area of controversy. It's kind of like the general anesthesia versus conscious sedation. Depending on what you do, if you work on the neck first, then it may change the actual time to recanalization. Cervical carotid stenting, although it may look like it's necessary at the beginning, oftentimes for the dissection cases, once you've passed your big guide catheter through, if you do the intracranial circulation first, when you pull your guide catheter back, the carotid artery is open. If you're going to put a stent in, then there's considerations about antiplatelets. Sometimes these patients have already at least some degree of ischemic injury, and you need to give a loading dose and maintain them on their antiplatelets once you've put that stent in. And so there's the concern about increased risk of hemorrhagic transformation, and there really is no clear consensus in the literature. So I'll go through a few cases that we've had in the last couple of months and just sort of show the different ways that these cases can go. So this was a 52-year-old woman who had a left carotid dissection, and she had progressive neurological symptoms. And you can see in her multi-phase CT that the image on your right is the later phase, and her left hemisphere perfusion was significantly delayed. And here's the reason why. So you can see she's got a long segment, pretty classic internal carotid artery dissection. She's got actually no antegrade intracranial flow. In this case, we could pass a microcatheter across, and we knew that her intracranial circulation was open. That is, this was a hemodynamic insufficiency case as well, and so we managed the neck here, and the intracranial circulation looked after itself, and her perfusion was restored. So a happy ending to that one. Here's a 48-year-old woman with a left MCA stroke syndrome, and you can see again on the CTA this time that there's an intraluminal filling defect. Her extracranial carotid artery looks pretty irregular, but she also has an intracranial T occlusion. So this is a much different situation. You can see her collaterals are not great. This was her angiogram. And even with passing a catheter through, you can see on the right is a later angiogram. She's got this double channel, double lumen. We did go up with a large catheter. We went up with a penumbra and aspirated and got a reasonable but suboptimal reperfusion. And that was her final result. Again, you can see in her neck that she still has a double lumen. It's fairly high, and she ended up with a fairly modest territory stroke and a degree of disability and went off to rehab. We decided not to stent that because we thought she was going to end up with a degree of an infarct, and we didn't want to put her on dual antiplatelets. This is a 60-year-old male, actually one of my colleagues at the Vancouver General Hospital, who came in with a left MCA stroke syndrome, and this was his CTA. You can see on the sagittal that there's less contrast density in the internal carotid artery, and he has a T occlusion as well. And this was his angiogram. And for people who talk about, like stenting the carotid dissection first as being the best way to go, if it's a straightforward patient with otherwise healthy arteries, and it's a low dissection and one that's straightforward to stent, that can probably be done in a fairly short period of time and may not add very much to the time. Then the consideration is the antiplatelets. This individual had a significant tortuous carotid artery just below his skull base, and you can see on the angiogram, not only is there tortuosity, but there's significant intraluminal clot. And this is not a situation where you want to be going up through that with a stent. So we actually did we went up with a penumbra, did an aspiration, got a reasonable reperfusion, and just from having the guide catheter up through the dissected segment, it actually opened up the narrowed part, and he was left with some intraluminal clot there, which on follow-up actually resolved. That was his final imaging, and this was his CT angiogram, I think, the next day, and you can see the dissection flap in his carotid. The intraluminal clot had disappeared, and his intracranial circulation stayed open. The last case I'm going to show is a 48-year-old woman with an acute right MCA stroke syndrome. This was a woman who was actually crossing the border from Canada back into the United States when she became acutely dysphasic. She was quite young, no stroke risk factors, but she'd had a spontaneous coronary artery dissection previously. And there's a hospital called Peace Arch Hospital, which is very close to the border, and she was taken there, and this was her CTA done at the time. And I think this kind of adds to the story, the discussion that we had earlier about these interfacility transfer cases and what kind of imaging that you do. You can see this patient, she had a high NIH stroke scale score, she had bad perfusion, but she was a young woman, came in, the neurologist, the stroke neurologist, fairly aggressive person. This was our pre-treatment CT scan, so we did a non-con head on arrival, which was about an hour and a half after the original studies had been done. This was this patient's scan. You can see a dissection in the neck and an intracranial occlusion. And even though we got a pretty good result, she ended up going on and completing the infarct as you would expect. So to summarize, Cervical artery dissection, it's a common mechanism of acute stroke in young patients especially. Internal carotid artery dissection with tandem intracranial occlusion, it responds poorly to IV TPA, and I think it should be considered for acute stroke intervention. We don't have an a priori preference as to managing the extracranial or intracranial circulation first, but in general, we'll probably go for the intracranial circulation if it's amenable. I think we probably shouldn't be too dogmatic about technical approaches and should be prepared to modify our strategy based on the patient's anatomy and their collateral circulation. And thank you very much.